I request our chairperson to introduce to our speaker, Dr. Professor Apoorva Jain, who is going to speak on the approach to hyponatremia.
Dr. Apoorva Jain is a MDDM, Professor Nephrology, SN Medical Agra. He is a medical director, Samarpan Charitable Trauma Hospital and Research Center, Agra. He is consultant nephrologist, Lotus Super Hospital, Agra. He is DM Nephrology from SGPGI, MD Medicine from GR Medical College, Gwalior. And his past professional experience is registrar in nephrology in the Prof Hospital, Delhi, consultant nephrologist, Pushpanjali Hospital, Agra, visiting consultant nephrologist, Varun Hospital, Aligarh, Ramkrishna Hospital. He has been speaker in multiple national and regional conferences like API, ICM, ISSCM, ISN. Publications are 20 national and international, 20 national and 8 international papers he has, and thesis guide has been he has been thesis guide to postgraduates. Dr. Apoorva, is a very interesting topic is hyponatremia probably. And hyponatremia is a very bizarre presentation sometimes. And if you know that it is hyponatremia may be suspectable, then only you can diagnose it. Maybe having varying symptoms like drowsiness, tremors, delirium. So I welcome Dr. Apoorva for his talk on hyponatremia. Welcome, sir.
Thank you. Thank you for the kind words. I'll straight away start with the presentation. It's going to be a bit exhaustive presentation. So as sir rightly said that it's a great masquerade as well as it's one of the therapeutic challenges in nephrology, internal medicine, surgery, pediatrics, almost all branches of medicine. Hyponatremia is a great therapeutic challenge in the way it presents, the complications that it has in its management, and the long-term sequelae of mismanaged hyponatremia. All these things they present as a challenge. So I'll try to elucidate the pathophysiology of hyponatremia and one of the major causes of hyponatremia, that is SIADH. And we'll try to provide a detailed diagnostic framework. We'll discuss the evidence-based management strategies of hyponatremia. We'll review the common complications, emerging therapies, and key studies, and we'll highlight some clinical pearls for complex cases and takeaway for common clinical practice. So the definition is very clear. Any serum sodium below 135 millimole per liter is hyponatremia. The gradations are mild 130 to 134, moderate 125 to 129, and severe less than 125. The timing, the acute versus chronic, any hyponatremia which is recorded in last 48 hours. So recording is very important. You need to have levels of serum sodium. One level which was apparently normal 3 days back, and a level which is decreased within a period of 3 days, 2 days. So both the levels should be recorded. Then it's an acute hyponatremia. And chronic hyponatremia, anything which is a more than 48 hours onset, is chronic hyponatremia. So prevalence, hyponatremia is largely under-recorded. It's not underdiagnosed. It is 15 to 30% in hospitalized patients and 7% in ambulatory settings. So there are certain high-risk groups. So high-risk groups are those patients which have generally reduced total body water, like patients in pediatric populations, elderly patients, patients who are in ICU. They are underhydrated patients, post-operative patient because of post-operative nausea and vomiting. And the other high-risk group patient, these are those patients in which there is increased effective circulatory volume, like in patients of heart failure and cirrhosis. So both the sides of total body water distribution, one who have decreased effective circulatory volume and one which have increased effective circulatory volume, both are preponderant to go into hyponatremia. So it is associated with a heightened mortality and morbidity almost 1.5 to 2 times as compared to their normal counterparts. So this is a chart which shows how does hyponatremia affect the morbidity and mortality. So we can see on the right side of the cartoon, in the yellow cartoon, as the serum sodium falls towards from 135 towards 110, there is a higher predicted rate of in-hospital mortality. And the lowest in-hospital mortality is it in the range group, is in the range of 138 to 142. That is almost normal serum sodium. So, large number of mortalities and morbidities in intensive care unit could be attributed to mismanaged hyponatremias. Clinical relevance of hyponatremia, symptoms. So it has a large variety of symptoms. We'll discuss about the symptoms in detail, but it could be very mild like headache and nausea to very severe like seizures and coma. The complication that it can cause, the complications are on both sides. So if there is an acute hyponatremia, by virtue of hyponatremia it can cause osmolar encephalopathy, that is hyponatremic encephalopathy. And if you correct the hyponatremia too rapidly, then it will cause osmolar demyelination syndrome. So on both sides, even when there is simple hyponatremia, the sodium is reduced rapidly over a short period of time, then also it can cause encephalopathy. If you correct it rapidly, then also it will cause encephalopathy. So both ways it can cause cerebral disturbances. Economic impact. Hyponatremia prolongs the hospital stay and increases the cost. So this is the array of symptoms caused by hyponatremia along with the relative distribution of symptoms. We can see that almost 19% patients of hyponatremia are asymptomatic. They may not have any symptom, and unless the lab testing is done, it will be under-recognized. So symptoms can be very mild. Like this is a patient of mild chronic hyponatremia, and we are looking at the gait disturbances. So at a sodium of 130, bit low than the normal, the patient had abnormal gait. And as the sodium correction was achieved, the gait became normal. So subtle symptoms need to be understood. We come to the pathophysiology of hyponatremia. So all hyponatremia is basically a disturbance of water. It is not a disturbance of sodium. So there is generally no net negative sodium in these patients. The actually a relative increase of water over the sodium. So it's basically a disturbance of water. So basic pathophysiology is excess water relative to sodium. Now, how will this excess water happen? So this will happen because of ADH dependent mechanism. ADH is antidiuretic hormone elaborated by posterior pituitary, and whenever there is increased ADH, it decreases free water clearance. So in these patients, water will be retained, and because water will be retained but sodium will not be retained, there will be a relative reduction in sodium compared to water, leading to hyponatremia. Sometimes there could be ADH independent mechanism where there is actual sodium depletion. Sodium may be lost in the urine. So there are certain conditions like cerebral salt wasting, or in certain patients which have hypotonic hyponatremia because of vomiting, etc. These patients may have actual loss of sodium, but these are very small number. Largest number of patients of hyponatremia are ADH dependent, where there is relative water excess, not net sodium loss. It is classified on terms of pathophysiology in three groups: hypovolemic, euvolemic, and hypervolemic. So what is the value of sodium? We look at the formula of serum osmolality. It is calculated as 2 times sodium plus glucose upon 18 and 1 upon 2.8. So this formula shows that calculated osmolality of blood is directly dependent upon sodium. It varies directly with the sodium. So sodium is the major defense of maintaining osmolality in the various compartments of our body: ECF, ICF, intracellular, extracellular. Sodium is the one which decides where the water will move from which compartment to the other compartment. So it maintains the osmolar pressure and helps in regulation of net water movement. If there is mild change in osmolality, we can say 1% change in osmolality from the range of plasma osmolality set point of 275 to 295, mechanisms are triggered on both sides. If there is increase in osmolality, there will be more thirst, water will be retained through ADH dependent mechanism. If there is a fall in osmolality, urine production will increase and net free water, that is sodium free water, will be lost and thirst will be inhibited. So both sides it is closely guarded. Who guards this? The guarding is through the ADH. ADH is elaborated by posterior pituitary. It acts on V2 receptors in the cortical collecting duct, and by virtue of this action, there is expression of aquaporin 2 channels in the cortical collecting duct on the basolateral side. And when these channels are introduced, then only water will be retained by the kidney in the terminal portion of nephron. So after that, there could be no more water excretion or reabsorption. It's the terminal portion of CCD is the terminal part. And this terminal water regulation is through posterior pituitary, which is in response to osmoreceptors, and osmoreceptors are working to defend two things. One is osmolality, and second is your blood pressure. As the blood pressure increases, osmoreceptor try to excrete water and try to retain water and decrease the level of sodium. So this is a summary of AVP action. Now we come to all three classes of hyponatremia one by one. First is hypovolemic hyponatremia. Cause is obvious. There has to be a loss of volume. So GI losses, vomiting. Most important is post-operative nausea and vomiting. It's a point which has to be highlighted multiple times in surgical patients, in patients with gynecological surgeries, orthopedic surgeries, general surgeries. Post-operative nausea and volume reduces effective arterial blood volume, which triggers ADH, retains water, reduces sodium. Diarrhea, very common. Thiazide diuretic. Now, these class of diuretics are major culprit. Patients have been put on thiazide diuretic for very long. And along with thiazide diuretic, the patient is asked to restrict his sodium intake. And many times these patients are the same prescription for years altogether without checking their serum sodium level. These patients are at a very high risk of hyponatremia because thiazide diuretic decrease free water clearance. They don't release water, they release more sodium compared to water. So pathophysiology, sodium and water loss will trigger ADH and thus the water will be retained. Key features, two important diagnostic feature is, first is low urinary sodium. In a patient of hyponatremia, if you find that the body is trying to retain sodium, then the most common cause is hypovolemic hyponatremia. And clinical examination, one can see the signs of volume depletion like tachycardia, hypotension, etc. The second is hypervolemic hyponatremia. So there are three group of patients which present with these symptoms. One, first is decompensated heart failure, second are decompensated cirrhotics, and third is nephrotic syndrome. In all three patients, there is increase in the there is reduced effective blood volume. So total body water is increased, but the water is not inside the vascular compartment. It has moved into the extravascular space. So effective arterial blood volume is reduced, ADH is triggered, and water is retained. So there is edema and water retention because of this. Key features, again, there is low urinary sodium and signs of volume overload. So low urine sodium with signs of volume depletion is hypovolemic hyponatremia. Low urinary sodium with signs of volume excess is hypervolemic hyponatremia. A third and the most common cause which we see in common clinical practice, usually underdiagnosed, is SIADH, which is a euvolemic hyponatremia due to excessive ADH. Now, it's a prevalence very common and most commonly seen in hospitalized patients. It has a great clinical impact because misdiagnosis can inappropriate treatment, and chronic cases of SIADH, the risk developing neurological complication. We look at etiology, there are myriad etiologies of SIADH. Almost all known drugs, every known disease can cause. I'm just highlighting the common and the most important one. The malignancies, small cell lung cancer, head and neck cancer, CNS disorder, stroke, meningitis, traumatic brain injury, pulmonary diseases, pulmonary tuberculosis, pneumonias, particularly acute bacterial pneumonia, they can cause severe SIADH. Medications, again very important, SSRI, the most common offending drugs which we see causing SIADH, carbamazepine and cyclophosphamide, and there are certain other states like post-operative states, etc. What is the pathophysiology? Here, there is inappropriate ADH secretion. Now, what is inappropriate? ADH secretion is to guard the osmolality of blood. So, if there is preserved osmolality, still there is ADH which is released, then it is inappropriate ADH. So, how do you decide whether there is appropriate or inappropriate? So, if there is normal to high urinary sodium, in this condition, if there is high ADH secretion, it becomes inappropriate. So, inappropriate ADH secretion leads to water resorption and thus causing hyponatremia. The key feature here are, this is very important, urine osmolality is high, that is more than 100 milliosm per kilogram, and urine sodium is more than 30 millimole per liter. To diagnose ADH, one needs to remember that if there is high urinary sodium in the wake of low serum osmolality, then it is SIADH. We need to understand this. If the serum osmolality is falling, still the body is keeping on excreting the sodium. In this condition, the underlying disease is SIADH. Clinical presentation, mild could present as fatigue, headache, nausea. Severe can present as confusion, seizures and coma. Physical examination generally uncharacteristic. The only thing that is to be recorded is in a patient of hyponatremia if there is euvolemic state, no sign of volume overload, no sign of dehydration. Lab findings, low serum osmolality and high urinary sodium. This needs to be understood. We can miss SIADH unless we go for urinary sodium analysis or urinary osmolality analysis. High urine sodium, high urine osmolality in the wake of low serum osmolality most of the time is SIADH. So diagnostic evaluation, the first is to confirm true hyponatremia, determine the etiology and identify the underlying cause. We go for a step-by-step approach. First, measure serum sodium. That is, it should be less than 135. Repeat testing to rule out lab error. Any abnormal serum sodium report, like a sodium of 125 when patient is alert and talking to you in your consulting chamber, go for reassessment of the sodium level. Exclude pseudohyponatremia, the severe hyperlipemia, hyperproteinemia, mannitol, etc., and check serum osmolality. Now going to assessment of serum osmolality, normal range is 275 to 295. Less than 275 is true hyponatremia. If there is high or normal serum osmolality, then it is pseudohyponatremia or hypertriglyceridemia. Third step is volume analysis. Hypovolemia, evidence of dehydration, euvolemia, uncharacteristic examination, hypervolemia, edema, ascites, high JVP, etc. Very important is to assess and appreciate subtle volume changes in elderly patients, which is very difficult, and these are the high-risk groups of hyponatremia. In elderly, because of loose skin, because of hypoproteinemia, it is really tough to understand whether there is excess volume or there is depletion of volume. Now going to lab analysis, we'll go for first urinary sodium. If the urine sodium is 30 millimole or more, then it is either SIADH or salt wasting diseases, renal salt wasting diseases. Urine sodium either 30 or more than 30 is SIADH or salt wasting. Urine sodium below 20 is hypovolemia or hypervolemic states. Going to urine osmolality, an osmolality of 100 milliosm per kilogram is inappropriate water retention. So if urine osmolality is high in a patient of low serum sodium, low serum osmolality, then this is inappropriate ADH release or SIADH, as I just outlined earlier. If the urine osmolality is low, less than 100, then it is psychogenic polydipsia. Patient is taking excess water because of psychological compulsion or low solute intake, tea and toast diet, dalia diet, low salt diet, etc. Additional tests which should be done in all patients of hyponatremia, thyroid disease should be ruled out, adrenal insufficiency should be ruled out, chest CT for malignancy. Any patient with chronic hyponatremia presenting with chest symptoms should be ruled out. We should rule out the non-small cell cancer, small cell cancer, brain MRI for CNS causes like meningitis, etc. Other tests like uric acid and BUN, both of which are reduced in SIADH. The fractional clearance of uric acid and fractional clearance of BUN, both are reduced in SIADH. Now, what is the diagnostic criteria of SIADH? We have discussed in our previous discussion. Serum osmolality should be low, urine osmolality high, urine sodium low, patient is euvolemic and does not have thyroid or adrenal disease. If all these 5 criteria are matched, the patient is towards SIADH. Supplemental is low uric acid levels and low BUN. Differential diagnosis of hyponatremia. SIADH is one of the differentials, and rest, first and most important, is cerebral salt wasting. So these are the patients which have got severe traumatic brain injury and hyponatremia and generally euvolemic and confused with SIADH. In these patients, we should look for high urine sodium with hypovolemia. Patients of SIADH are generally euvolemic, but CSW patients are hypovolemic. Although said easily, but really difficult to diagnose bedside whether it is SIADH or CSW. Adrenal insufficiency, low cortisol and hyperkalemia, hypothyroidism, elevated TSH, and psychogenic polydipsia, low urine osmolality. We go to the treatment principles of hyponatremia. Goals are 1, to correct the sodium, 2, to treat the underlying disorder, and 3, most important, minimize or avoid complication like ODS and cerebral edema. Correction rate, it is very contested, but the accepted guidelines, the lowest is the recent one I have given, 4 to 8 millimoles per day. Maximum is 10 to 12 millimoles in 24 hours. In high-risk patients, chronic and severe hyponatremia, the correction should be even less, 4 to 6 millimoles per day. Acute symptomatic hyponatremia and chronic hyponatremia are two common clinical presentations we'll discuss. Acute symptomatic hyponatremia, how do you define it? There should be severe degree of neurological involvement, seizure, coma, severe neurological symptom like patient is obtunded, altered sensorium, etc. This is the minimum indication to treat acute symptomatic hyponatremia with these treatment guidelines. The drug of choice is hypertonic saline. 100 to 150 ml is given bolus over 10 to 15 minutes and repeated up to 3 times if needed. Symptoms should abate. One should not look for correction of sodium. It is just the abasion of symptoms which is important. Target is 4 to 6 millimoles increase over 6 hours, and then we'll go to slow correction, that is 8 millimoles over 24 hours or 10 millimoles over 24 hours. Monitoring. Whenever acute correction is attempted, sodium should be monitored every 2 hours. Why? Because this is a dynamic state. Every time we are correcting a patient of hyponatremia, the renal excretion of sodium is also changing. So this is a dynamic balance. One is taking sodium from intravenous route, and the level he is excreting from kidneys can vary. So if the excretion reduces because of change in the original etiology, or because of the correction of the original etiology, the correction rate will become very rapid. So every 2 hourly it should be monitored. And neurological status, the GCS should be charted on the file, and we'll discuss later. It can cause serious medical legal implication if the serum sodium and the GCS is not charted on a 2 hourly basis in a patient where severe hyponatremia is being attempted, correction is being attempted. Chronic hyponatremia, most important is identify the cause. Look at the prescription. Look for thiazide diuretic, SSRI, carbamazepine. Look for chest CT. Look for his neurological examination, imaging, lab workup, etc. Volume-based treatment in hypovolemic hyponatremia, isotonic saline. In hypervolemic hyponatremia, diuretic, loop diuretic, and fluid restriction should be attended. In euvolemic, that is SIADH, we have already mentioned the treatment. Now, SIADH treatment. The first line treatment is reduce the amount of salt-free water. Reduce it to less than 500 to 1000 milliliter per day. This is generally effective in mild to moderate cases where most of the patient of SIADH will fall. Patient compliance remains a challenge because such low levels of water intake, particularly in tropical climates, in extreme summers, is really tough. And so patients of severe hyponatremia may not respond to this alone. So here comes the drug, the vasopressin V2 receptor antagonist. The two approved ones are oral tolvaptan and intravenous conivaptan. One which we commonly use and it's available in India is tolvaptan. There are two indications of tolvaptan. One is refractory SIADH and second is severe hyponatremia. It should not be started in moderate hyponatremia. The dose of tolvaptan is a graded dose, 15 to 60 milligram per day, depending upon the response. But very important key thing is to ensure that whenever tolvaptan is used, we should be sure that it is euvolemic hyponatremia. All the tests to prove the urine osmolarity, the serum osmolarity, the urine sodium, serum sodium, thyroid, adrenal, these should be worked up before starting this agent. Urea, this is mostly of academic purpose, no more used nowadays. Other therapies, two things which I would like to stress. One is loop diuretic. Loop diuretics are very valuable drugs in treatment of hyponatremia because they have got positive free water clearance. So Lasix and torsemide, furosemide and torsemide both have positive free water clearance. They restrict salt intake but increase water excretion. So they restrict water excretion but restrict salt excretion but enhance water excretion. That is positive free water clearance. Sodium tablet, they may have a limited role, but in conjunction with fluid restriction, they work wonderful. If salt supplementation with fluid restriction is practiced in euvolemic hyponatremia, the results are fantastic. Monitoring, serum sodium should be monitored, neurological examination should be monitored, recorded, volume status and urinary output. There should be adequate free water clearance while monitoring this. There are two complications we'll discuss shortly. One is osmotic demyelination syndrome, that is ODS. The risk factors are overcorrection. If the correction is more than 12 millimoles in a day, if the patient was chronic hyponatremic, malnourished or alcoholic, the symptoms are dysarthria to begin with, paraparesis if it gets more advanced, and locked-in syndrome. The pseudobulbar palsy can also happen. Prevention, very important is to use desmopressin in these group of patients to maintain slow correction in these patients and careful monitoring of neurological symptoms. ODS can be extrapontine or central pontine. We can see the typical trident appearance on FLAIR MRI images. The other complication of hyponatremia, as I discussed in the starting of my presentation, is cerebral edema, that is osmolar encephalopathy or hyponatremic encephalopathy. Acute hyponatremia lasting more than 48 hours. This leads to low serum osmolality, water shifting into the brain. Brain swells up, herniates, and this can cause seizure, coma, obtundation, and even death. Management is hypertonic saline and urgent correction. So this is a swelled up brain of hyponatremia, and these are the sites of potential sites for herniation: the subfalcine herniation, transtentorial, the most common, and the tonsillar herniation, which can happen because of rapid correction, as well as chronic severely hyponatremia, which is uncorrected. Now, pitfalls in management. SIADH, inappropriate isotonic saline. Never give isotonic saline in patients while managing SIADH. Why? Because in these patients, isotonic saline is hypotonic to plasma. So actually it increases water retention. So anything below 3% osmolality will not work in these patients. So 1.6% saline, 0.9% saline, these should not be used in patients of hyponatremia. Don't miss an underlying malignancy in patients of SIADH. Overcorrection, failure to use desmopressin in high risk patient. Whenever there is a high risk patient, the patient is neurologically altered, along with 3%, use desmopressin spray so the correction rate can be checked. Undercorrection, if you do not correct adequately, fearing the complication, then it leads to undercorrection. Emerging approaches are novel vaptans, ADH receptor modulators, and gene therapy. There are certain biomarkers which are under study like copeptin, uric acid, and on the basis of genomic profiling of V2 receptors, we can predict the vaptan response. So which patient will respond to vaptan on what scale? This can be predicted using pharmacogenomic profiling. So finally, certain clinical pearls which can be taken away from this: always measure serum osmolality to rule out pseudohyponatremia. Always use urinary sodium, urine osmolality, plasma sodium, plasma osmolality. These four tests in all patients we are suspecting SIADH. Always consider malignancy, use of thiazide diuretic or a salt-free diet, which is in Western literature called tea and toast diet, or in India it is dalia diet, the sweet dalia diet, particularly in the elderly patients. Rule out adrenal insufficiency and hypothyroidism. In the management, avoid isotonic saline in SIADH. Do not use isotonic saline. Do not use vaptans in acute hyponatremia. Always try to use desmopressin whenever you are correcting acute hyponatremia with hypertonic saline. Monitor sodium frequently during correction, 2 hourly when very rapid correction is being attempted, and at least 3 times a day when slower correction is attempted. Remember to document GCS imaging records to avoid legal hassles in these patients. So this is the Ardrog Medias formula which is being used to assess the dose of 3% saline, but there are certain medical calculators available. One of the calculators I have suggested, this is MD Calc, and there are 3 schemes when you can use to either detect the sodium deficit. You can also find out the sodium correction rate according to sex, age, and weight of the patient. And you can also find out the free water deficit in patients of hypernatremia in these by using these calculators. These are very simple calculators, app-based calculators. And with this, I've finished my topic, and I'll be happy to answer if there are any questions.
Hello. Thank you, doctor. You had made this topic, which is very difficult,
I can't see you.
very easy one. It's very, in ICU, in critical care medicine, hyponatremia is a very common problem and very commonly seen. And the treatment and the management, which as you told, is very important and very nicely illustrated to the audience. I think now it will be very easy for ourselves to maintain sodium level and water balance in ICU, especially in the post-operative period, in case when there is in coma and other non-emergency cases. This sodium balance is very important. Thank you, sir. Is there any question?
यूजुअली हम लोग खाली सोडियम करा करके रह जाते हैं. We have learned that urine sodium and osmolality is always important, and that should be done in all the cases. Otherwise, we just get the serum sodium and start correcting it.
For
Thank
all
you very much
electrolytes, for
for
all
the nice
electrolyte, we should
information.
remember that it is expressed in terms of free water. It's milligram per DL. So that DL part is also very important. If the DL is high, the milligram will be low.
We
It's
usually
always
don't
relative to the amount of total body water.
we don't get it routinely, but we'll think that we should do it. Thank you much.
हेलो टैबलेट कितने दिन तक यूज करते हैं?
Sir, sodium tablets. Tolvaptan. Okay. So tolvaptan, in certain conditions, it can be used indefinitely. There are certain diseases in which it can be used indefinitely, like patients with cirrhosis. If there is chronic hyponatremia and patient is able to maintain sodium only with tolvaptan, then it can be used. Certain patients of SIADH, the moment you take tolvaptan off, they go back into hyponatremia. So tolvaptan is required. If the basic cause remains, because in large number of patients of SIADH, the basic cause remains unidentified. It's very few patients it is identified. Most of the patient it remains unidentified. So if there is an unidentified cause of SIADH which is influencing the free water excretion, then to maintain the free water excretion, some amount of tolvaptan needs to be taken. Dose can be moderated. You can give it daily dose. Sometimes I also give it alternate dose depending on minimum urine osmolality I am comfortable with.
I would like to call President AMA, Dr. J.B. Rai, Organizing Secretary Dr. Anurag Singh, Secretary AMA Dr. Ashutosh Gupta for the felicitation ceremony. I request all the chairperson along with the speaker to come on the stage. लास्ट सेशन है, लास्ट टॉक था, प्लीज एक जोरदार तालियां हो जाए.